Hi, my name is Shayla DeBay, and I will be presenting on Ehler-Danlos syndrome. Ehler-Danlos syndrome, also known as EDS, is a group of disorders that affect the connective tissues. Connective tissues are important because they support the skin, bones, blood vessels, and other organs and tissues in the body. Defects in the genes affecting connective tissue cause the signs and symptoms of EDS. Diseases can vary from mild to severe with complications. There are 13 subtypes that exist, with the most common subtypes being classical EDS, hypermobile EDS, and vascular EDS. Per the National Institute of Health, EDS can be acquired via autosomal dominant, autosomal recessive inheritance patterns, as well as through de novo mutation. In an autosomal dominant disease, if you get the abnormal gene from only one parent, you can still get the disease. You have a 50% chance of passing the disorder on to a child. In an autosomal recessive disorder, you inherit two mutated genes, one from each parent, and have a 25% chance of passing the disorder on to a child. De novo mutations are ones that appear in an individual despite not being seen in their parents, essentially as a new mutation that can be passed along. This occurs in about 50% of cases with Ehlers-Danlos syndrome. Ehlers-Danlos syndrome can be caused by a number of mutations with different genes. Some commonly affected genes include the COL5A1 gene, which can cause a form of Ehlers-Danlos syndrome called the classical type. COL5A2 gene provides instructions for making a component of type 5 collagen. Type 5 collagen is important for blood vessel walls, synovium, corneal stoma, tendons, lungs, bones, cartilage, and skeletal muscle. COL1A1 and COL1A2 genes provide instructions for making type 1 collagen. Type 1 collagen is important for bone, skin, dentin, the cornea, blood vessels, fibrocartilage, and tendons. The COL3A1 gene provides instructions for making type 3 collagen. Type 3 collagen is important for skin, ligaments, blood vessels, and internal organs. A mutation in the TNXB gene causes hypermobile EDS, which is the most common found form of EDS. A mutation with the PLOD1 and FKBP14 genes are found with kyphoscoliotic EDS. ADAMTS2 gene provides instructions for making procollagen, which is the precursor to collagen. This is a chart created by the Ehlers-Danlos Society describing the 13 subtypes of EDS by their inheritance pattern. The most common forms of EDS are classical, vascular, and hypermobile, which have an autosomal dominant inheritance, along with arthrochalasia, myopathic EDS, which can be either, and periodontal EDS. Autosomal recessive inheritance is found in classical-like EDS, dermatosporaxis EDS, kyphoscoliotic EDS, brittle cornea syndrome, spondylodysplastic EDS, musculocontractural EDS, and myopathic EDS. There are no known risk factors to Ehlers-Danlos syndrome. As mentioned before, having parents affected with the mutated gene increases the chance of inheritance, although half of all cases are new mutations. The condition can affect all ethnicities, and there are no known environmental risk factors associated with the condition. The prevalence is estimated at 1 in 5,000 births. Disease presentation can vary depending on the subtype, although there are some overlapping symptoms. Taking a patient's history, it's important to ask about these general symptoms. EDS is often underdiagnosed, so it's important as a provider to dig a little bit deeper when patients present with the following history to give clues for this underlying genetic disorder. It's important for the provider to ask about skin hyperextensibility, easy bruising, joint hypermobility and subluxation, which commonly presents with frequent ankle sprains or knee buckling, tendon rupture, abnormal wound healing, surgery complications, fatigue, and musculoskeletal pain that occurs in both the patient and their family members. With so much variation with the physical findings for each condition, I wanted to focus on the three most common types. With vascular EDS, it's the most serious with the poorest prognosis, particularly serious because of the risk of spontaneous arterial or organ rupture. The physical findings for vascular EDS include fragile tissues that are prone to rupture, thin translucent skin, uh, distinct facial characteristics including thin lips, a small chin, thin nose, and large eyes, acrogaria, which means premature aging of the hands and feet, hypermobility of small joints, early onset varicose veins, pneumothorax, easy bruising, joint dislocations and subluxations, congenital hip dislocation, congenital clubfoot, and receding gums. Classical EDS tends to affect the skin more. The common manifestations include smooth, velvety skin that is highly elastic and bruises easily, abnormal wound healing that results in flat or depressed scars, joint hypermobility that leads to frequent dislocations and subluxations, molluscoid pseudotumors, which are bluish gray, spongy nodules seen over easily traumatized area, such as the chin, forearm, and tendo Achilles, subcutaneous spheroids, which are small, hard cyst-like nodules that are freely movable over bony prominence of the legs and arms. Hypotonia is also common, delayed motor development, tissue fragility that may lead to hernias, cardiovascular abnormalities such as mitral valve prolapse or aortic root dilatation, and also pregnancy may be complicated by the premature rupture of membranes. Hypermobile EDS is considered the mildest form of EDS, and it's characterized by joint hypermobility. You see symptoms such as soft, smooth, and fragile skin, hypermobile joints, frequent joint dislocations, scoliosis, and osteoarthritis. With hypermobile EDS, you can see unusually soft or velvety skin, mild skin hyperextensibility, unexplained stretch marks on the back, groins, thighs, breasts, and/or abdomen in adolescents, men, prepubertal women without a history of significant weight gain or loss, bilateral papules on the heels, recurrent or multiple abdominal hernias, atrophic scarring, pelvic floor, rectal, and/or uterine prolapse in children, men, or nulliparous women without a history of morbid obesity, dental crowding, and a high or narrow palate, abnormally long fingers or toes, an arm span to height greater than or equal to 1.05, mitral valve prolapse, and aortic root dilatation. Diagnosis for EDS is made usually based on clinical history and physical exam, and it heavily depends on the subtype of EDS. Certain subtypes can be tested via skin biopsy with electron microscopy. An abnormal biopsy can signal the need for DNA, blood, or saliva testing. The DNA extraction will show the mutated gene on cultured fibroblasts. Hypermobility EDS has no blood testing available, but there are multiple criteria that must be met. A screening tool that can be used for hypermobile EDS is the Baton hypermobility criteria. The Rumpel lead test can also indicate capillary fragility. With EDS, clotting factors are usually normal. This is a chart from a test guide for the three main types. It shows that classical EDS can be tested with a classical EDS panel and a comprehensive EDS panel. Vascular EDS can be tested by looking for type 4 in the blood. Hypermobility does not have a specific test. Red flags to look out for are very important with EDS. As a primary care provider, patients with EDS presenting with these symptoms need to go to the ER to prevent further complications. These red flags include sudden onset of pain or bleeding, sudden onset of dyspnea, orthostatic intolerance, visual loss, and acute chest pain. Unfortunately, there is no cure that exists for Ehler-Danlos. The treatment focuses on management and prevention of worsening symptoms. An interdisciplinary approach is needed, usually integrating cardiology, dermatology, orthopedics, PT, OT, and ophthalmology. Assessing gait, avoiding contact sports, and avoiding skin trauma are helpful for protecting skin and vessel integrity. Genetic counseling can aid in helping patients understand their diagnosis. Since EDS has a focus on prevention, for vascular ADS, it's important to incorporate periodic screening for aneurysms, avoid injury to prevent bleeding, and avoid elective surgeries due to the high risk for rupturing of arteries, muscles, and internal organs. For classical EDS, it's important to integrate physical therapy, assistive devices, anti-inflammatories for joint pain, use of protective bandages or pads to protect fragile skin, and to monitor children for aortic root dilatation. With hypermobile EDS, physical therapy can be used to strengthen muscles and improve joint stability, as well as assistive devices, pain medicines, and it's important to monitor for osteopenia and as well as aortic root dilatation. As there is no cure for EDS, up to date, the Ehler-Danlos Society and the NIH have published guidelines for the management of EDS, which can be accessed via the links on the slide. There are multiple resources that exist for clients or those that are interested in the condition. The Zebra Network, the Hypermobility Syndromes Association, and the Ehler-Danlos Society all provide support groups, patient education and handouts, promote awareness, have memberships, and have conferences for those who are interested in learning more. Listed on the slide are references used for this presentation. This concludes the presentation. Thank you for listening.